Good morning, good afternoon. Hello and welcome to the webinar. I'm Selena Schocken, Executive Director of Together for Health, a partnership focused on increasing access to cervical cancer prevention. We hope that you and your family are safe and comfortable during this difficult time. We're pleased to co-present this webinar in partnership with our colleagues at the International Gynecologic Cancer Society. In today's webinar, we will hear from the IGCS leadership as to how they are supporting their members to deliver essential cancer services at this challenging time. We'll also hear from clinical experts about considerations for defining and delivering essential sexual and reproductive health services, including cervical cancer care, in the context of the COVID-19 pandemic. A few logistics before we begin. All attendees are on mute. Questions can be submitted in the Q&A box at the bottom of your screen. We'll take a few questions after each presentation if time permits. More questions and answers will be available towards the end of the event. The webinar is being recorded and will be available on our website, togetherforhealth.org, a few days after the event. Now we're going to get started, and I wanted to briefly introduce our colleagues from the IGCS. Mary Eichen is a senior association executive for over 20 years with experience in the field of association management, with most of the time spent in gynecologic oncology. In April 2016, Mary became the first CEO of the IGCS. Her experience in governance, policy, strategic planning, and volunteer engagement has brought incredible opportunities and positive change to the IGCS. And after Mary speaks, we'll hear from Dicey Jackson-Scoggins, a 23-year ovarian cancer survivor and health activist. She's the Director of Global Outreach and Engagement for the IGCS. She's also chair of the Advocacy Special Interest Group for the African Organization for Research and Training in Cancer, and a co-founder of In My Sister's Care, an organization focused on improving gynecologic cancer awareness and care for medically underserved women and on eliminating health disparities. Mary?
Thank you so much for that kind introduction and for the opportunity for IGCS to partner with Together for Health in this important topic. I thought I would start by giving a little bit of a background just on our membership at IGCS for those of you not familiar with our organization. Next slide. We are a membership organization. Next slide. As Celine mentioned, I began with IGCS about a little over 4 or 5 years ago. So we have really grown our membership as we continue to meet our mission of really being the global international organization for gynecologic oncology. Our global reach is about 110 countries. You can see here that depicted. So we're really excited about our reach in both upper, mid, and low resource settings, which allows us to make our mission and live up by our mission every day. Next slide. Probably our best flagship program is our Global Curriculum Mentorship and Training Program. It's a 2-year program, a web-based curriculum, where we match institutions from programs and regions with formal gynecologic training, somewhat like a twinning program. The goal is to train 1 to 2 fellows per year at each site, and we do this in collaboration with our local hospitals, universities, and ministries of health. We have, in 2017, we piloted these 4 sites: Vietnam, Mozambique, Ethiopia, Kenya, and you can see who they are, their twinning sites are with. And then in 2018, we moved into other regions of the world that include, next slide, Guatemala, Uganda, Zambia, Jamaica, and now in 2019 and 20, we've expanded even further. The next picture just shows some of the training that we do. This is our site in Mozambique, where we are doing our training both in the OR and obviously outside the OR as well. Some of the challenges that we have faced, next slide please, with the global curriculum and COVID is our ability for our trainees to participate in surgical rounds. Obviously, the operating room cases have gone fewer and far between now for our fellows. Next slide. But we have been able to keep in touch with them in technology like we're using today. We conduct several COVID tumor boards. We do case presentations. We provide a didactic. We have stopped all site visits right now at our training programs. And as I mentioned, our surgeries have been somewhat limited. The next slide shows a really nice depiction of our sites together learning through this amazing technology that we're here today, and could be somewhat of the future and the way in which we conduct education during this time. And finally, we are encouraging our fellows during this period to look at doing some type of research and publications, preparing abstracts, both for our journal, for other meetings that might be happening throughout this pandemic time and a virtual opportunity. And finally, we put together an annual report. I would encourage you to go to our website and look at our annual report and all the way in which we have impacted mentorship and training globally. We also provide, next slide please, our membership the opportunity to participate in community discussions and forums. We've tried to make this very COVID-centric during this time, but I think people, especially in our membership, like the idea of still feeling connected in times when they're uncertain and when we will gather again together as a community. As Selena mentioned earlier, next slide please, we are especially proud of our outreach and engagement. Dicey Scroggins, who will speak after me, is our director of this activity, and we have found increased enhanced activity, again, as people look and seek opportunity to kind of join and be together. We'll be doing further virtual patient roundtable series that will commence in about 10 days. May 23rd will be our first. But the general idea was that these be structured around the COVID-19 pandemic and addressing gaps and needs in this always changing and evolving situation. We hope that it shows our commitment to facilitating interactions, a forum that will allow increased knowledge base around important issues to survivor and caregivers, not only in COVID-19, but also in other important areas, including clinical trials, the opportunity to learn journaling, and many other things that Dicey will do with our patient roundtable series. The next slide just shows some of the examples of the topics that will be covered. As I mentioned, clinical trials, ongoing care, survivorship issues, post-pandemic life, and genetic testing, just to name a few. And then finally, we like to keep everybody informed through our journal. We are especially proud of our journal. Our editor-in-chief is Pedro Ramirez. He does an incredible amount of work in providing not only the latest in peer-reviewed science through our journal, but lots of other opportunities, we believe, for our members and our community to gather during this COVID period. So in conclusion, I'd like to again thank all of our partnership with Together and our ability to work with you. We believe we're positioned and committed to providing timely and relevant information to the gynecologic oncology community globally, both during this time of COVID and for the foreseeable future as well. So thank you again for this opportunity. I'm pleased to hand this now over to Dicey Scroggins. As was mentioned earlier, Dicey is our director at IGCS of our global outreach and engagement. She wears many hats, and we are so proud and thankful to have her as part of our team.
Thank you so much, Mary, for that introduction, and thank you, Together, for including us in this really important session. I'm going to talk a little bit about patient engagement and voices, and the fact that it is critical to care and to service provision. I just want to emphasize the fact that in these times, it is even more important than it is on a continuous basis. Next slide, please. So I have a little tribute that I always do with every presentation that I give on to patients and survivors and to other clients as well. I think it's important that we anchor ourselves, and this is by way of anchoring. I'm not going to read it, but it's here just to indicate that, you know, patients, survivors, women and children, I mean, communities advocate, they educate, they participate, they do all of these things, and that all of us must stand with them. And I personally stand in awe of all that's done. Could you please go to the next slide? Okay, this next slide is just to say a little bit about how we view issues of outreach and engagement at IGCS. We try to reach as broadly as we can, and we make sure that we engage across all kinds of dimensions, certainly income levels, race and ethnicity, you know, geography, zip code. One of the things that I think is important and that we understand at IGCS is that there's an intersection, a strong link between where you live, your zip code and your postal code, and the kind of care that you receive and the likelihood of outcomes. And so we strive to make sure that wherever you live and under whatever circumstance you might live, that you receive high quality care. We understand that community, the health of community flows through women. So we have to make sure that we take good care of women worldwide, and that we provide avenues for them to help in quotes, taking care of themselves. We create avenues for interaction, and so that their voices can be magnified. This webinar is an instance of that kind of interaction. We'd like to empower women and girls with tools and the awareness, the sources, the resources that they need so that they can make their own choices and enable them to act on their own specific needs rather than to always be acted upon. It is important that they have healthcare autonomy. And we celebrate women and men who are engaged in these battles and engaged in communities' efforts to be healthy all over the world. And one of the ways that we do that certainly is through our Distinguished Advocacy Award, which I'm sure we'll be able to share information on later. Let's move to the next slide, please. So these are just ways that I think of patient and community voices and why they're important. They share, provide, clarify, differentiate, amplify, and solidify. They tell us what's real in the world. They tell us what's real in their world, so they get their lived experience. They provide nuances in terms of what their needs are and how they can receive information and services and so on. They clarify things for us. We may think we understand certain things, but they make them more clear. They will differentiate between what we believe to be true and what is actually true on the ground, or that in fact our beliefs might be a bit off. And they bring up the whole volume in terms of amplifying understanding. They bring up the volume and increase the sense of urgency. They certainly solidify relationships, which is extremely important. So they are reality checks, including them in all of our conversations, such as these, are tacit acknowledgement of their value and connotes the respect that we hold for them and that we understand their importance. And let's go to the next slide, please. So in COVID-19 pandemic response and beyond, we must just be sure that we have patient voices at every conversation, always at the table, and that they're never simply passive recipients. We must include women and girls in all of our conversations. And these conversations like this one, where we talk about them, we determine what their needs might be, and we plan a healthy future for them. They need to be a part of these conversations. We must assume and always proclaim the value of their words, the input, the things that they will tell us that no one else knows. And then through our actions, through how we implement programming and so on, we let them know that we've heard them, that we understand their importance, and we honor them. And in closing, sort of in their own words, they'll guide us to the important areas that are important to them, and we need to listen very carefully. They'll tell us what they need and how we can best serve them, and we simply need to listen and then act. Next slide, please. Thank you. You can find more information on the outreach and engagement programs at IGCS at the address here, and you can also contact me at dicey.scroggins@igcs.com. Thank you so much.
Thank you so much, Mary and Dicey, for your overview of IGCS and for the important perspective of thinking about cancer patients during this important time. I'd like to just quickly call your attention to the Q&A box at the bottom of your screen. If you have questions for our presenters, please ask your question there so that I will be able to address them to the presenters. I'd like to turn now to Professor Greta Dreyer. Professor Greta Dreyer currently heads gynecologic oncology at the University of Pretoria and the Steve Biko Hospital in Pretoria, South Africa, where she's actively involved in academic medicine as a clinician, researcher, and teacher. An IGCS council member, she's also co-founder and director of the HPV Cervical Cancer Research Fund. Much of her current research focuses on methods to improve access to and effectiveness of cervical cancer prevention strategies. Professor Dreyer headed the revision of the South Africa's National Cervical Cancer Prevention Policy, and she is going to be speaking on the response to COVID-19 in South Africa and Africa. Professor Dreyer? Professor Dreyer, can you unmute yourself, please? Professor Dreyer, we can't hear you. If you can please unmute yourself. Please go ahead.
Can you hear me?
Yes, please go ahead.
Thank you. Firstly, I really want to say, I'm sorry, but I cannot see your screen. Can you just attend to that, please? Firstly, I want to thank you for the invitation, and it's really a privilege to be on this webinar. I was then asked to speak about the COVID and the response to the COVID epidemic, also partly because the disease is just really hitting Africa and South Africa, and also because as far as South Africa goes, we have really been trying quite hard to actually assist and help our obstetric gynecology society to respond to this. Can I have the next slide, please? Can I have the next slide, please? So the themes that I wanted to address is really, as listed there on the screen. I think it's really critical that we look at the relative importance of things and the rationale to reach the conclusion about what we should prioritize during epidemics. It's really the harm caused by the alternative health disease and the intervention that we plan to do, and the gain that we can expect. And then secondly, the harm that we can actually expect if those other interventions are omitted, even if that is just temporary. And also the gain which we can potentially have if those interventions are omitted or postponed. And there, of course, we're specifically thinking of having improved care and outcomes for the victims of the epidemic and freeing more staff space and money and capacity in our facilities to really attend to the COVID epidemic first and then shelf the rest a little bit. The next slide, please. So the way to reach this type of disease, decision is really to look at then the global prevalence of sexual reproductive disease. And here you can see that while Mary's screen showed in Africa in green, if we look at the prevalence of cervical cancer, Africa and many other parts of the world is really very much red and orange with very high prevalences. Next slide, please. The other issue is not only the global prevalence, but also the age prevalence and the age distribution of this disease. And this slide shows you that especially in HIV, among HIV positive women, cervical cancer really is very prevalent amongst younger women, and that we see the disease affecting young women. And this is contrary, of course, to what COVID does. So we have to protect our young population also against the disease, and the protection against cervical cancer can be influenced then by what we prioritize during the COVID epidemic. Next slide, please. The same goes for the prevalence of CIN. Now, this slide, if you really had time to look at it, will probably shock many people on the webinar, because the prevalence of precancerous lesions in the South African population, specifically any population with a high prevalence of HIV, is completely different from what we see in populations with low HIV and high screening. You can also see that there are little small green bars on top of all these age prevalence CIN lesions, and those are invasive cancers. So one of the things that we do during cancer screening is we actually detect invasive disease already, which is different from many other programs in the world. Next slide, please. So what we then have to do is really finding a balance between how we manage COVID and how we manage other sexual reproductive health and what those interventions are. And that balance depends on the size of the local COVID epidemic. So there is no one size fits all, and the importance of that then, and the age distribution, etc., which I've shown you. And then the age distribution and the potential impact of the loss of focus if we actually shelve women's reproductive health rights and cares and so on. Also, of course, the history of those rights and the management of that per country will differ, and that changes the priorities as well. Can I have the next slide, please? So the other thing is then, if we have decided that we need, and this is of course the decision, that we need to continue sexual reproductive health services during the COVID-19 epidemic, how do we actually make sure that we can do that safely and sustainable? And really there we want to focus in terms of sexual reproductive services during this time specifically on obstetrics and the delivery of services to pregnant women, because that is so time sensitive. And then contraception can never be omitted or postponed, because that will lead to another catastrophe in 9 months. And then cancer diagnosis and care is something also that absolutely needs to be a frontline essential service. At the same time, we have to identify cases of active COVID. We have to make sure that there's appropriate PPE and that is handled correctly. And we have to separate patients with high risk from those with low risk. I'll also allude a little bit to how we should pay meticulous attention to the cleaning of surfaces, equipment, hands, etc. between patients. Thank you. Then if we focus on these things, what are the principles then? Next slide, please. What are the principles then of the safety and sustainability? Really, firstly, that we have to optimally care and manage the severely ill, that we have to protect our healthcare workers, and that we have to protect patients against nosocomial infections. So regarding optimal care for ONG patients, this is very often an inpatient issue especially, but also when you are looking at outpatients, it's extremely important that everyone knows how to differentiate mild disease from severe disease, and how to identify patients with severe COVID disease for supportive multidisciplinary care and hospital admission. The obstetrics really need the route of delivery, breastfeeding, etc., is not really affected by COVID. And it's just important so that we care for the women, and ongoing care is done in a careful and protected way. The other issue that we often see is that patients would present with a high fever, which is then potentially COVID. But they then present also with a gynecological issue like vaginal bleeding or potential miscarriage. And here it is really important that there should be simultaneous investigation and treatment for both the COVID disease and the most probable alternative diagnosis. And if we do not do that, we will lose patients to the alternative diseases. Next slide, please. So the next issue is then, how do we protect healthcare workers? And everybody knows there's been so much going on, so many webinars, so many information leaflets about how we should actually wear PPE. It's a little bit of a new thing for many, many of us. But basically at the moment, the care is that the focus is that staff at risk of severe disease should be kept out of high-risk areas, and workers must really wear appropriate full PPE in these areas. And the rest of us should absolutely wear a mask at all times when in contact with both patients, community, and other staff members. Second, I also want to say that I think the threshold for testing healthcare workers must be very low because of the high prevalence of disease in healthcare facilities. Next slide, please. We then also have to make sure that we protect patients against getting nosocomial disease. And here it is extremely important to actually separate patients with high risk from uninfected patients. So because we are hotspots, we need to make sure that we identify high-risk patients. Susceptible patients are then kept outside, but for the rest of patients, it is quite impossible to identify every person with asymptomatic disease, and therefore we need universal precautions, and that is the mask and that I've already alluded to, and of course social distancing. The other important thing is that when we have planned admissions to healthcare facilities, our position is that those patients must all be screened and tested because that is really the only way to keep your healthcare facilities safe. The challenge here is, of course, how to afford that, and for many countries that will be a big challenge. The next slide, please. Lastly, I want to talk about equipment and the fact that we really need to just really make very sure that our equipment in both inpatient and primary healthcare facilities and outpatient areas are cleaned in a different way from before. We really need to make very sure that we have terminal cleaning before we use a room for an unconfirmed case, and then of course in our clinics as well. While wearing universal protection and face cover, we also need to make sure that patients are distant from each other and that the equipment is very, very sufficiently cleaned. You can actually in these times also not use the same clothing for more than one patient. So we need to really a shift of focus and another way of thinking during these times. Next slide, please. I would like to end by saying that I think working in Africa have given many of us the opportunity to actually be almost better prepared for this epidemic and suboptimal type of situation than people who are used to having everything optimal. We have extensive experience with competing health priorities in Africa. The HIV epidemic shifted everything else out of the focus, made it impossible for us to do our normal work, and moved our budgets into the HIV area. We also have in Africa, and this is not really true for South Africa, but many other Africans do have extensive experience with highly contagious virus epidemics. And they have developed very often innovative healthcare workers, lab workers, scientists. Our population in Africa is younger, robust, tolerant, and resilient, and we are more used to adverse situations than many other people in the world. And that also goes for our unique socioeconomic and disease profile, which, of course, in some ways threaten us. We have inherited and gotten from the world the virus, but also quite a lot of experience about how to contain it. There's a lot of virus sequencing, PCR tests, etc., that we already have received from Africa, countries outside Africa. And for that, I think all of us are very thankful. There are many guidelines, recommendations already developed. I do think that those need to be redeveloped for our for our own unique circumstances. And then, of course, the digital communication that we're using today and the technology of that is also very welcome. And Africa has really embraced digital communication methods already. And it's really something that enables us. And unfortunately, there's also a lot of uncertainty, fear, and social media messages, which is really a problem for us and which we need to address. I would like to conclude with the next slides, please. Firstly, I want to say in conclusion that we have to remember that this is a short-term or at most probably a medium-term problem, and we need to actually look beyond the pandemic and make plans for the long run as well. And then we have to change our thought process, and all of us have to start thinking like a public health specialist. The last slide, please. I think then what we need to do with this pandemic is really to limit the damages. Firstly, we need to limit the damage done by the viral disease and the COVID disease itself by making very sure we treat the disease well, we make sure that healthcare worker exposure, morbidity, mortality is all limited. And then we need to limit the collateral damage. And here specifically on sexual reproductive health services, it's important not to interrupt the momentum that we already have and to also focus on long-term service delivery. And then, of course, also the collateral damage on other disease outcomes like cervical cancer diagnosis and care, pregnancy as well. And then lastly, social outcomes include, of course, unwanted pregnancy and intimate partner and domestic violence. I'm ending here, and I thank you again for the opportunity, and the webinar will, of course, be open for questions at the end. Thank you, Heather.
Thank you so much, Dr. Dreyer, for your very thorough and useful presentation. I wanted to ask you one quick clarifying question that came in from Gabrielle Rocha Rios. And she asks, what are some recommendations for women who are due for a pap smear or a test during the COVID-19 period? Should that be postponed?
I think the answer to that is actually really differs per individual circumstances. Now, there are countries who are in the midst of an epidemic where all the healthcare workers are pulled into the COVID response. And I think for that situation, it is not appropriate to have your next pap smear at this time. However, if there is capacity and the service is delivered and there are possibilities to have the pap smear, there is a real gain in having it because we will then limit the backlog. I think it's more important to manage what we have already screened and found to be abnormal. And there I would feel that we should really make sure that patients with abnormal screening tests are managed and diagnosed fully. But I think that we can actually have, just postpone screening a little while, and that will have a really limited damage in the long run.
Great. Thank you so much, Dr. Dreyer. I'd like to move now to Dr. Millie Kagwa. She is the Senior Clinical Advisor for Sexual and Reproductive Health for Anglophone Africa at Population Services International. In this role, Dr. Kagwa serves as the technical focal point to ensure clinical teams deliver high-quality, evidence-based care. Based in Kampala, Uganda, she oversees a service delivery portfolio that spans over 30 countries, and she focuses on sexual and reproductive health, prevention of unsafe abortion, and cervical cancer prevention. And just before Dr. Kagwa starts, if I could just call your attention again to the Q&A box at the bottom of the screen. We will do questions and answers at the end of Dr. Kagwa's presentation. Please go ahead, Dr. Kagwa.
Good morning, good afternoon, and good evening. Greetings from Kampala. Next slide, please. Next slide, please. Yes. I think the figures on this chart are not very new to most of you. Today, 90% of all cervical cancer occurs in women in lower and in middle income countries, with more than 300 women dying each year. And we see more than 500,000 women being diagnosed annually, and every minute one woman is diagnosed. So this is really a dire situation, this is really dire. And along with other sexual reproductive health services, we're seeing that life-saving interventions are remaining unavailable for majority of the women and girls. And if we do not act, we anticipate that there will be deaths from cervical cancer increasing by 50% by 2040, undermining the existing investments and health gains that have been made for women in maternal health and HIV care. And these losses will be particularly acute in countries already affected by the HIV burden. If you remember from the previous presenter slides, that's what we anticipate to see. Next slide, please. So the next slide is just showing PSI's footprint, where we're operating. We're operating in Asia, in Latin America, and also in Africa. Next slide, please. And the COVID pandemic is really challenging health systems across the world, not just in Africa. We're seeing increasing rapid demand for tracking, identifying, and care of people who have COVID-19, but this is compounded by limitations on movement of people and supplies. And this has disrupted delivery of frontline healthcare, including sexual reproductive health and cervical cancer. PSI has developed these Srh priorities to help guide us during the Srh pandemic. The first is to keep Srh needs at the forefront and as part of national COVID-19 response. This Srh is one of those health areas that can easily become not a priority during emergencies. So at PSI, we are encouraging our country platforms to keep Srh at the forefront and where possible to be part of that national response. And then we're also encouraging countries to innovate around the interventions. It's no longer business as usual. If women cannot come to the facilities, providers are having difficulty getting to the facility, how do you meet a client's voice, choice, and even urgency for sexual reproductive health, including cervical cancer? And again, PSI has a network of franchise clinics in over 25 countries. This network includes over 10,000 facilities. How do you manage COVID exposure risk in those PSI supported facilities and the communities that they serve? And then if women cannot access the health facility, how do you get clients to manage their own care since they don't have enough access to providers or the interface has been limited? How do we encourage self-managed care for clients? Next slide, please. And we've seen that the pandemic has definitely heightened the vulnerabilities of women, especially women and girls. They are marginalized. We've seen contraceptive access has been reduced. We've seen access to safe abortion has also been reduced, and cervical cancer screening has definitely been affected by the pandemic. And despite this being considered essential preventive services, the actual access is not there for women. PSI programs have adopted their interventions to try and meet some of these essential needs. People are thinking outside the box. How do we get services to women through the unusual routines, such as using motorcycle riders to get them their family planning pills, for instance. Next slide, please. So for this presentation, I'm just going to talk about the case of Uganda and how the COVID pandemic has actually created challenges and what opportunities have also been realized when this has happened. The Ministry of Health in Uganda has developed guidance and recommendations for observing precautions for COVID-19 prevention. And while Srh is considered an essential service, including family planning. Not much is mentioned about cervical cancer. So we are seeing, as you see later in my later slides, you're seeing a decline in Srh services as a whole, but the decline is really hard for cervical cancer. PSI has supported health facilities in adapting these guidelines from the Ministry of Health, such as the use of personal protective equipment, hand washing, and social distancing, but that has come at a cost with reduced women walking in for services. That has come at a cost for providers who cannot afford. And we've seen the challenges there's been a big shift in attention from sexual reproductive health to COVID-19. The travel restrictions have reduced access, not only for the provider, but also for women. And some women have mentioned, how do you expect us to get out of the house when we're when we're in a lockdown with our husbands? And usually we use the excuse of going for market days to get our family planning, for instance, but now we don't have that excuse anymore. So some newspapers are actually reporting an anticipated baby boom in Uganda at the end of the year. Already we're experiencing commodity stockouts, and these are anticipated to continue because of the travel restrictions right from the source where, for instance, family planning commodities are developed. But there are some opportunities there. The ministry has developed guidelines for sexual reproductive health in the context of COVID, and they've called out sexual reproductive health as an essential service. So any partner, any implementing partner who can observe the precautions for COVID-19 prevention and can provide an innovative way of giving services can then continue. Please go to the next slide. And so we've seen, just to give you a little bit of context, PSI Uganda, through its local affiliate PACE, launched cervical cancer screening in 2012. And this is, the program runs through a franchise of network providers called ProFam, offering sexual reproductive health, including family planning, cervical cancer screening using VIA, and then cryotherapy in selected facilities. Women who present for cervical cancer are also made aware of family planning options such as IUDs, and providers have found that there's an increase in both uptake of these services. Next slide, please. So this is this is what we saw in 2019 around cervical cancer screening. As you can see, there were over 1,000 on each month apart from December. December is a unique year, a unique month in Uganda. Services practically come to a stop because providers and actually also their communities break off for Christmas. So that is not a unique picture, but you're seeing that they were seeing clients, and there were a few positives in there. Next slide, please. This slide, I just put out this slide to show that the need for cervical cancer programming is still very high. The blue bar that you see shows women who were eligible for cryotherapy, but they did not receive that service for a variety of reasons. So there is still a need to see how women can be either referred to the correct center, followed up to make sure that they get the services that they need, and so that we can see eligibility with no blue, so the blue bar is not there anymore. Next slide, please. In 2020, PSI teams had planned to introduce thermal ablation services, train providers in screening, and at the beginning of the year, they recalled the cryotherapy machines for servicing and maintenance, and that's when COVID-19 struck. There's a reason why you don't see even Q1 figures for 2020. And clearly that's going to be the impact on cervical cancer, where we think that there'll be very few services that are seen within the next 6 months in Uganda. This picture, I pulled it out from a national paper, The Monitor, and for even a pregnant woman to get services, they must get a permit in Uganda from their regional district office, but the lines are pretty long. So the lines are pretty long. Women have to wait sometimes more than 1 day to get their services. And a provider has mentioned that they've seen a sharp decline in women seeking for sexual reproductive health services, especially family planning and cervical cancer. women will rarely walk 5 kilometers or more to get these contraceptives or to get Srh services. So definitely we're seeing a decline in services. Next slide, please. So what next? Because the situation isn't going to change overnight. What next? And this is what PSI Uganda anticipates. They anticipate that there's a need for implementing MOH guidance on to be able to have service delivery at these clinics. Implementing the COVID prevention guidance will allow facilities to open, will allow women to come in. But these women, how are we going to create demand for women to come in for services, to draw them back to clinics? And knowing that cervical cancer falls down the list of sexual reproductive health priorities, unique ways have to be thought of on bringing women into the clinics. PSI Uganda is also thinking that there's behavior messaging around integrated services, integrated sexual reproductive services is very key during this COVID period of time, because otherwise cervical cancer will not be a priority at this time. And then how do we use the digital interventions that exist to understand the client needs and then to help them with their care so that they can be able to themselves look and seek for this care. And of course, there's still a need for appropriate personal protective equipment. There's still a need for training. There's still a need for equipment. And there's also a need for supporting providers to continue providing cervical cancer services. Next slide. And thank you. We've come to the end of my presentation.
Thank you so much, Dr. Kagwa, for an excellent presentation. It was very thorough and many useful insights that you had. So we've come to the question and answer part, and I see that we're starting to get some questions coming in. I wanted to start with a question from Carrie Thompson. She is interested in hearing from the presenters whether social distancing and the reluctance of visiting health facilities might add some momentum to HPV diagnostic self-sampling. Clearly, we couldn't do that policy right now, but as we move out of COVID-19, might self-sampling be an option for the future? So if I could have the speakers unmute themselves if you would like to answer that question. Professor Dreyer?
Very interesting and excellent question and suggestion. We are working already with really home care, home visitors type, non-healthcare workers, volunteers being trained to actually take HPV self-sampling to the home of many women. And I definitely agree with this, with Kerry, that we should really be embracing opportunities to get our disease and our interest on the radar. And this is an excellent way to do that. Of course, the majority of women who are then self-sampling will not need any further treatment, and they will not need to come to the health facility. So this is a fantastic idea, and I think something which already happens in many places on the globe. The other option is to use the postal service, and that I think is an even better opportunity for more developed situations.
Thank you very much. Another question actually for you, Dr. Dreyer, is from Trudy Smith asking, how often would you suggest that healthcare workers test themselves for COVID-19?
When I wrote the recent guidelines for South African Society of ONG, I thought about this and then added a sentence which said the ideal time frame and frequency is unknown. So I don't think anybody knows the answer to that question. It is actually, although it is an expensive test, it is not exuberantly expensive. So I think, to do this regularly is doable. The problem, of course, is that the epidemic might be very protracted. So to do it weekly for a month is doable. To do it weekly for 6 months is going to be very difficult. I would like to know Trudy's opinion on that.
It's a good question, certainly a challenging question. Thank you.
The other part of the challenge is who is going to pay for that. And
Yes.
if the employer pays, then I think we are all willing to do it on a weekly basis. The problem is that, you know, we are limited by funds and resources.
Mm-hmm. Yes. We have a couple of questions that have come in for Dr. Kagwa. Dr. Kagwa, if you could take yourself off of mute. The first question is, in Uganda, are the screening facilities not offering cryotherapy? What kind of treatment are they offering?
Yes, that's a good question. In Uganda, the clinics that I am talking about mainly midwife-owned clinics. These are domiciliaries, and they're lower-level facilities that are using VIA for screening. Most of them will not have cryotherapy available. Only 13 facilities out of around 100 had cryotherapy facilities. And cryotherapy comes with the challenge of cost of maintenance, availability of spares, availability of gas. And the Uganda platform is actually thinking of introducing thermoablation because the machines could be portable, and the training can also be done for midwives, clinical officers who pretty much run these clinics. So much as it is ideal, it is not readily available in each facility.
Thank you. Another question that has come in is specific to Uganda, but I think it also applies to South Africa. And the question is, how has PSI, or how are other providers, in the case of Dr. Dreyer, mitigated the fears in the health workers of contracting COVID-19 while providing sexual and reproductive health services?
I have two answers to that. The one comes from my father, who used to say we get used to everything. And I have seen during the COVID pandemic, epidemic, that is actually true. We're also getting used to the idea of risk, and that may be good and it may be bad. The second answer is that I have always found in my professional career that knowledge takes fear away. So that is probably the best way to actually manage fear. And I think that if we protect people, we give them the ability to understand and protect themselves. That is the way to go.
Thank you. Dr. Kagwa?
Yes, I think in Uganda, it has been very, very helpful when the ministry provided guidance, and this guidance has been disseminated. We've actually had a very active communication, sometimes even daily, from the ministry, talking about the COVID-19, talking about prevention, talking about risks. And I think even just providing simple things such as personal protective equipment, masks, and hand washing stations, and providing that guidance for facilities has given some providers, has taken away some of that fear. I think it still exists, but it is now a little bit more controlled. We still see clinics operating, and they're actually some of the only essential businesses that are open.
Thank you. I wanted to take the chair's prerogative and ask a question to each one of our presenters. I'll start with Mary and then Dicey, and then move to the others. And my question is, once it is safe for women to return to the health centers for non-urgent care, what are some of the best ways that we can build trust? And I know we've gathered some of that experience through Ebola and through other crises, but now is a time to start thinking about how to build that trust to encourage women to, when it's safe, to return. So Mary, could I start with you?
Yes, I think it's important that we continue. COVID has provided us this opportunity to really open up lines of communications with each other, with professional societies, with our practitioners. I think the use nowadays, currently with the telemedicine, I think we have to continue this transparent and open communication so that patients do feel confident and comfortable as they re-enter the space of screening, diagnostic, and ultimately the potential for treatment in this period.
Great. Dicey?
Hi. Yeah, I think that it's important that before we're ready to move into the next stage, that we begin to ask women and families about their fears and their concerns, so that we know exactly what it is that they need and what they would most benefit from. And then I think we need to turn to community health workers or people whose opinions are valued in the community, people who maybe have, informal authority, informal leadership within communities. To ask them what they think would be necessary. And then I think we need to provide information through sources where they usually receive information. We need to go to the women and to the people. We don't need to expect for them to come to us with questions.
Great ideas. Professor Dreyer?
I think everything about COVID is about prioritizing, and during the pandemic, and I think shortly after it, when we are regathering our economies and everything else, also our healthcare, the most important thing will be to actually decide what will make the biggest difference. And in cancer care, most certainly the biggest difference is made if we actually resume and hopefully never interrupt cancer treatment. And here I'm talking about invasive cancer. In terms of other sexual and reproductive health services, for me, contraceptives is an absolute priority which can never be stopped. And I think we must make very sure that we do not drop that ball during the pandemic. After the epidemic, when we are resuming, I think cancer screening and the management of pre-invasive cancers will become a very, very important priority again. And we will have to employ also then catch-up programs.
Thank you. And Dr. Kagwa?
Yeah, I think, like as the other presenters have said, communication is really key. I think one of the ministries in Uganda, one of their messaging is around malaria, and I think they've given out that message that despite having COVID-19, the other health areas have not, and other burden has not gone away. We still have malaria, we still have all the other health problems that we had before, and so they're keeping women and the communities knowing that there's still a need for that. We shouldn't forget about those. And we should be also thinking about prevention of those other health conditions. So I think that's really very important. There was another question in the Q&A where somebody asked about facilities in Uganda, do they have radiotherapy? I would like to say that that's, I think, one of the biggest gaps in Uganda. The health facilities I'm talking about, none of them has radiation therapy. Radiation therapy is available only in national hospitals, and they are far from many women. So if we can screen for cancer and prevent rather than waiting for women to come in for treatment, I think that's really the most important thing for Uganda. And back to COVID and Srh services. For Uganda, the cervical cancer has to be integrated with sexual reproductive health. I think that's a really low-hanging fruit for us, making sure that whenever we speak of contraception, everybody is aware about the needs for contraception. We should also be speaking about cervical cancer.
Thank you. Now, I'd like to ask the last question to each one of our speakers. And I just want to give you an opportunity to address anything that wasn't covered, and to talk also, if you see, what do you think is the biggest challenges you're facing, and what is an opportunity that we're seeing now in the response to COVID in our sexual and reproductive health work? Mary, could I start with you?
Sure. I think, continuing to encourage women to put their health as a priority, especially during this time. Sometimes as women, we don't always do that, right? So I think definitely continuing to prioritize themselves, to make sure that they make appointments, that they keep their appointments, and that they really stay connected and engaged with their providers, their clinics, and practitioners that they would normally see in person in some type of a virtual format if possible.
Thank you. And Dicey?
Yes, I think that one of the real concerns for in many communities is either mixed messaging or no message. So I think we need to be consistent with messaging in these changing times. And I know the message may change daily, but it needs to be consistent and it needs to be focused on issues that are important to communities, women, families, and so on. And I think we need to focus differently and message clearly.
Thank you. Professor Dreyer?
Well, just two things stand out for me that we haven't paid a lot of attention to. The one is intimate partner and gender-based violence, which was alluded to, but I do think that we need to make it possible and easy for women to actually complain about these problems. And we also need a very clear strategy about how to address it. And that goes for everyone in the space of women's health. The second thing is I would like to say that I think that we often place obstacles in the way. And I think the epidemic should be a time when we reconsider many of the obstacles that we are placing in women's ways. And I'm alluding here also to that picture of women waiting for some sort of document to give them the opportunity to go and see their doctor because they're pregnant. I think that type of obstruction that we place in the way of healthcare is very problematic, and we tend to actually blame women for bad care, but we should be blaming ourselves, and we should be really looking at how we can remove those obstacles. And I think this epidemic can be a way to do a good time also to focus on that. Thank you.
Thank you for those thoughts. And Dr. Kagwa?
I think it is important to have consistent and correct messaging. During this time, there's a lot of information that some of it ends up bombarding people until they don't really know which is the correct message and which is messaging that is not as, doesn't make sense. So getting correct messaging out there is very, very key from trusted sources that if information comes from this source, it is trusted by the community.
Great, thank you. This brings us to the end of our webinar. I would like to sincerely thank our speakers and participants for such an engaging session. Thank you to our speakers for the important work they're doing and for taking the time to speak with all of us today. We will post this webinar on our website, togetherforhealth.org, within a couple of days. Thank you and be well.